I mean, during ESMO 2022 in beautiful but rainy Paris, we had the honor on Monday afternoon to present the first results from Cosmic 313 study in advanced renal cell cancer. This is the first trial that uses a control arm, a modern control arm, contemporary control arm, not sunitinib. It's actually nivolumab and ipilimumab, so it's double IO. The experimental arm was nivolumab ipilimumab plus cabozantinib at 40 milligram a day, knowing this is placebo-controlled study. The primary endpoint was progression-free survival by independent central review, and the study actually met its primary endpoint, hazard ratio 0.73, corresponding to a clinically meaningful and statistically significant 27% decrease in the risk of death or progression. Some other element to consider, the toxicity was higher, so more steroid use in the triplet arm. There was also more diarrhea all grade, more skin toxicity all grade, not high grade, but there were more LFTs increase. We don't know if these LFTs increase, transaminases increase, are immune related, are due to TKI, or a combination. But actually, treatment discontinuation of the three study components occurred in 12% in the experimental arm and 5% in the control arm of nivolumab ipilimumab. I mean, this is a great question. I think we still need to wait for overall survival. But one interesting thing that emerged, despite all hazard ratios were less than 1 in subgroup, except in poor risk. When we look at poor risk, that are only 25% of patient, intermediate was 75%, we see same response rate and same PFS. You know, the hazard ratio is the same. You would have, I mean, this is a bit counterintuitive. You would think a triplet regimen work more in poor risk. On the other hand, maybe these patients are very sick, you know, and don't get enough of anything. So the intermediate risk patient fared actually better. This is a large chunk, 75% of the population. The hazard ratio from 0.73 in the total population of PITT to 0.63. The response rate difference became 10%. So we want to follow that signal. But I think the bottom line, this is a positive study with a control arm that is contemporary. One of the things that stood up is the HIF2 inhibitor-based studies. And this is a very important and new target in renal cell cancer. That target and drug led in part to the 2019 Nobel Prize in Physiology or Medicine, including one of my close friend and colleague, Dr. Bill Kalin from the Dana-Farber Cancer Institute, in part investigating at the basic level oxygen sensing. So HIF2 is part of the story, if you want, from an oncological but also cardiological perspective. So we knew there were two updates from studies. One was VHL syndrome. The drug is approved. Belzutifan, the HIF2 inhibitor, is approved in VHL syndrome. With more mature data, the data looks stable, looks good, looks robust. We also have data with combination, cabozantinib plus the HIF2 inhibitor belzutifan in previously treated patients. I had the honor to present this data previously. The update of the data looks good. Patients are stable. Patients, do well. But what we presented here was Dr. Mershon and myself. We presented data in untreated patients. First line, no IO, untreated patient, 35 patient, cabozantinib plus belzutifan, response rate 57%. PFS, 30 months, although I would argue that it's a bit unstable. The follow-up is shorter than 30 months, but no PD. This is interesting. We're going to follow on that. And this really favors the two ongoing phase 3 trials. One second line with TKI lenvatinib plus belzutifan versus cabozantinib. The other one, very promising, with Dr. Rini, myself, is a triplet arm with pembrolizumab, lenvatinib, HIF2 versus pembro, len, and there's a third arm containing CTLA-4. Exciting time in RC. John, I want to remind you, 2005, when I started my fellowship, median survival, metastatic RC 1 year. Now, 5 years. So I think this is great. We are not going to stop till every patient is cured, hopefully in this lifetime. I think the third segment, there was a very interesting session. Really, we waited this session on Saturday with two studies in the adjuvant setting. Prosper with neoadjuvant adjuvant nivolumab, and Emotion 010 with adjuvant atezolizumab in high-risk renal cell cancer. Unfortunately, and unlike Keynote 564, that study was, both studies were really negative, dead negative. The hazard ratio 0.9. You know, a lot of difference in study design, in drugs. Dr. Tom Powles, I invite you to see his discussion, did a masterful discussion, putting it into context. And a day later, Dr. Bob Mozer presented in the presidential session adjuvant nivo-ipi, but for 6 months. And that also, showed, quite interesting result, but at the end of the day was negative. So we have adjuvant atezo a year, neoadjuvant adjuvant nivo, 1 year of 6 months of nivo-ipi, high-risk RCC, all negative. Only Pembro 1 year is positive at 24 and 30 months. No OS benefit. There's a trend. We're going to follow on that. I think renal cell, as a disease is evolving very fast, message by message. People ask me every time if my practice is changing, and I'm like, my practice is evolving by every meeting. I can't keep up. My slides are getting old, meeting by meeting. I cannot update them. But this is, at the end of the day, this is great news for patients.